what I'll have you do is, Doc, that you will introduce yourself, because you do that better than anyone else. And then I will just have an introduction on what our goal of the program is, and what we want to get out of it. So, hey guys, thanks a lot for coming today and joining our webinar. We do have Dr. Amjad here. Dr. Amjad is from Georgetown University, works at Medstar Hospital. He is a movement disorder doctor, neurologist that sees clinical patients. I think that's important. Our goal of our program today is that we're just going to talk about more than movement in terms of Parkinson's disease. 10 years ago, we knew that Parkinson's was a movement drug and not much more about that. Today, we know a lot more, that there are other things that are associated with Parkinson's, such as mental health, behavior changes, mood symptoms, sleep, as well as hallucinations, delusions, maybe some jealousy that go along that. So that's what we're going to talk about. Mental health plays a huge role in some of those patients with Parkinson's. About 50% of patients will experience some sort of mental health and hallucinations, delusions. So today we're just going to learn more about it. If you have questions, feel free to type them into Karl. We can answer them ongoing or at the end. But also, too, I just want to make it a point that if you do have serious questions, we really want you to contact your healthcare provider and have your healthcare provider, deal with those issues and those questions on a personal level, because they know much more about your situation that Dr. Amjad does, Karl, or myself. So it's important that we say that. But the importance of today is to really just increase our knowledge, to learn more about a disease state, and have options that could help benefit you and your caregivers. So having said that, please let's welcome Dr. Amjad. Dr. Amjad, introduce yourself as you would. Thank you.
Thank you, Brian, and thank you, Karl, for having me, and for all of you for joining us and learning a little bit about Parkinson's disease and some of the non-motor symptoms of Parkinson's, which, like Brian was saying, 10 years ago, a lot of what we did focused on the motor aspects of Parkinson's. And we'll talk a little bit about how some of the non-motor aspects of Parkinson's can be far more debilitating than some of the motor aspects. Before I get too far, and I'll introduce myself in a second, Karl, you may have to allow me to share my screen, because it says, oh, you did. Okay.
Just did. Yeah, I just remembered.
Let's share this and put it in. Okay. Can you all see the presentation?
It's loading.
It's loading. Okay. All right. So while it's loading, so I'll tell you a little bit about myself. And before I forget, this is a sponsored event by Acadia for pimavanserin or Nuplazid. My name is Fahd Amjad. I practice. I'm a trained neurologist, and then I subspecially trained for 2 years in movement disorders. And now I have a movement disorder practice at Georgetown University Hospital in Washington, D.C. I probably see anywhere from 120 to 130 Parkinson's patients a month. And Parkinson's disease is the bulk of what I treat, probably about 80 to 85% of what I do in my outpatient practice. And Parkinson's disease psychosis, which we're going to talk a little bit more about today in detail, is something that I see almost on a daily basis. In fact, I saw 6 patients this morning, and 2 of them we're dealing with this exact thing. And so we'll talk a little bit about that. Let's see. Okay. So one of the things that I always like to start my talks off with, and before we get to this slide, one of the things I always like to start my talk off with is that Parkinson's disease is really a systemic disorder. So what do I mean by that? What I mean by that is that every major organ system in the body that you can think of is involved in Parkinson's disease. And there are really 2 reasons why that happens. One is that Parkinson's disease affects the autonomic nervous system. So that's the part of the nervous system that sort of operates in the background. We don't really think about it. I'll give you an example. So it's what, 1 o'clock. So some of you have had lunch. Your stomach is digesting that food. The intestines are busy absorbing all those nutrients. You have increased blood flow going to the gut so that all those nutrients can be absorbed. But you're not telling your brain, you're not telling your body to do that. But the brain sort of is taking care of that automatically. And that's the job of the autonomic nervous system. And that part of the nervous system is impaired in Parkinson's disease. The reason it's pertinent to our discussion today is that a lot of the medications that are typically used to treat hallucinations and delusions also drop your blood pressure. And so we'll talk a little bit more about that, but I want to make sure we set the right context. So remember, Parkinson's disease is a systemic disorder. One of the main reasons it affects the autonomic nervous system, and more specifically, it affects blood pressure regulation. It drops your blood pressure when you stand up, and that's something called orthostatic hypotension, or more specifically, neurogenic orthostatic hypotension. So that's one aspect. The other reason Parkinson's is a systemic disorder is that it affects every major neurotransmitter system in the brain. So what are neurotransmitters? Neurotransmitters are, you can sort of think about them as the messengers of the brain. So they're little chemicals, tiny little neuropeptides that allow one part of the brain to talk to another part of the brain. And so when we think about something as simple as picking up a pen, there's several different parts of the brain that were just activated in that simple act, and they're not all next to each other. They're separated from each other. And so neurotransmitters allow the different parts of the brain to talk to each other. So the other way to sort of think about that is a network of neurons.
Question, is Dr. Amjad? Yeah. He dropped out. Okay, he'll be back. We'll get him back. Brian might be gone. So I'll say until he returns. Really interesting because but my experience, here he comes. All right, good.
Hi, did I drop off? Are you guys still there?
Yeah,
Yes, we're still here.
Yep.
Sorry about that. I'm not sure what happened. How far, where did you lose me?
We were to the part where you were saying about the areas of the brain having difficulty communicating with each other.
Okay. All right. Let me see if I can put this back
Yeah.
in slide. Yeah, let me see. Okay. So what I was talking about was a network of neurons. So this network of neurons, the basically cells or parts of the brain that aren't right next to each other are separated in space within the brain. And so neurotransmitters allow these different parts of the brain, or this network within the brain, to talk to each other. And there's a network that is responsible for movement that's affected in Parkinson's disease. There's a network of neurons that's involved in mood and anxiety and depression that's also affected in Parkinson's disease. There may be another network that helps us make sense of reality, what we're seeing and hearing, and that's also affected in Parkinson's disease, and that's what leads to hallucinations and delusions, and we'll talk about that in more detail in a few minutes. But the idea, the main point of this is that the second reason Parkinson's is a systemic disorder is that it affects every major neurotransmitter. So it affects almost every major network within the brain. And if you think about some of the non-motor symptoms of Parkinson's disease, depression, anxiety, cognitive effects, sleep disorders, acting out of dreams, hallucinations and delusions, all of these are non-motor symptoms of Parkinson's disease that we didn't really used to talk about. 10 years ago, all we focused on was dopamine. But now we're starting to realize that there are lots of other chemicals or neurotransmitters in the brain that are affected, including serotonin. So we're going to talk a lot about serotonin today. One of the ways I sort of like to think about serotonin is it's the mood lighting for the brain. So it sets the, if you walk into a McDonald's versus a nice Italian restaurant, one of the first things you're going to notice is the lighting. It sets the mood or the ambiance of the place. That's what serotonin does for the brain. And so if serotonin levels are low, it leads to an increase in depression and anxiety. And serotonin also plays a major role in hallucinations and delusions. And pimavanserin, the drug that we're going to talk about towards the end of this talk, really works on serotonin. It doesn't affect dopamine. Why is that important? The reason that's important is that in Parkinson's disease, dopamine levels, and I think everybody's familiar with this, are very low. And so if dopamine levels are low, that affects your motor system. And so that's the reason why people will sometimes have tremor, rigidity, slowness of movement, or bradykinesia is the fancy word for it, and postural instability or balance problems. So those are sort of the UK Brain Bank criteria for the diagnosis of Parkinson's disease. They're all motor symptoms and they're all affected by dopamine. But one of the main things that we need to understand about treating hallucinations and delusions is that traditionally the way we treated them was by blocking dopamine. And if you and that's the way we treat. So for example, if somebody has a psychiatric illness, the classic one is schizophrenia. If somebody has schizophrenia, they hear voices, they may talk to these voices, but the way we treat that is by blocking dopamine. And unfortunately, because we didn't have anything else until 2016, that's the way we treated patients with Parkinson's disease. We would block the dopamine receptor. But the problem is that if you block the dopamine receptor in a patient in whose brain dopamine levels are already low, you're going to dramatically exacerbate the motor symptoms. And now, for the first time in 2016, we have a drug that controls hallucinations and delusions without affecting dopamine. It only works on serotonin. Again, we'll talk a little bit more about that. So what are hallucinations and delusions? So a hallucination is seeing something that isn't there. So I'll give you a few examples. If you see, I had a patient, I'll give you some specific examples. I had a patient a few years ago, and he would walk down the stairs and he would always fall at the bottom of the stairs. He never fell anywhere else. And so, we were talking at one of the visits, and he said, the reason I see this puddle at the bottom of the stairs, and I try and avoid that puddle, and that's what was leading to his falls. Now, the puddle wasn't really there. That was a hallucination. So seeing something that isn't really there, that's what a hallucination is. And hallucinations come in many forms. The most common form of a hallucination in Parkinson's disease is going to be visual. That's the most common type of hallucination that's seen. But there are lots of other hallucinations. So sometimes patients may hear things. Patients may hear music. A few years ago, I had a patient that would hear bees, and so she called the exterminator to the house because she kept hearing these bees. The exterminator came out to the house 10 times, and they never found any bees. That was an auditory hallucination. She was hearing something. I've had patients tell me that, I distinctly remember this one patient. I used to see him, it's probably been about 10 years now. And he, every time he would sit in a chair, he would feel like the chair, there was a rope digging into the back of his legs, which made it very difficult for him to sit in a chair, but it was a tactile hallucination. So sometimes you may feel that something is touching you. I had a patient about a month ago tell me that she felt like her dead husband was sort of touching her on her back, trying to get her attention. Again, a tactile hallucination. So the hallucinations can come in many forms. Usually they're visual, but they can come in many forms. Delusions, and so delusions are important because delusions oftentimes are even more problematic than the hallucination. So delusions are, it's a fixed belief. It's this irrational sort of belief that is not amenable to reason. So for caregivers, it's important to realize this because This isn't something that you can talk your loved one out of. This isn't something where you can present data and have them say, oh, this makes sense. Okay, I understand what you're saying. It's not amenable to reason. A delusion is a fixed belief. Men oftentimes have delusions of jealousy. So a very common delusion for men is this idea that their wife is cheating on them. I've seen lots of couples where that has been a significant source of conflict in the marriage, until we were so able to intervene and sort of educate a little bit that your husband isn't being isn't being a bad person. This is part of his Parkinson's disease, and this is part of the delusion. And if we treat it, the treatment for this is oftentimes very successful. And that leads me to my next point, which is that if somebody is having this, it is incredibly important to bring this up. Doctors are not very good at bringing this up. In fact, 9 times out of 10, we won't bring it up. Patients oftentimes are not great at bringing this up either, because there's a lot of embarrassment, there's a lot of stigma associated with this. But it is important that if this is happening, to bring it up to your treating physician. And the reason is that we have good treatments for this. This is not something that you have to live with. It is something that is very debilitating oftentimes. This is one of the leading causes of why patients end up having to leave their home. When one of my patients gets admitted to a skilled nursing facility or to the hospital, about 25% of the time, it's because of this. So again, if we can identify this and we can treat this, we can keep patients in their home, and we can keep them, we can keep them functioning at home. So there was one other thing I wanted to mention, which isn't on this, and that is an illusion. So illusions are not so much a hallucination. They're sort of I call them the little brother or sister of a hallucination. So they are, they're a milder form which will eventually turn into a hallucination. So I'll give you an example. Remember what I said about the network. There's a network within the brain. There's a group of neurons or a system of or different parts of the brain that work together to achieve a goal. And so I gave you the example of picking up a pen. There's a network of neurons that allows me to do that. And those neurons talk to each other by using these tiny little chemicals called neurotransmitters. There's also a network within the brain that allows us to interpret what we are seeing and hearing. And if that network is corrupted, if that network isn't working right because of Parkinson's disease, remember, Parkinson's disease sort of starts in the bottom portions of the brain, and as the disease progresses, it starts to spread to the top portion of the brain. It's the networks that help us interpret reality live in that top 5, 10 years after the diagnosis. That's when you start having problems in the networks of the brain that help us make sense of reality. And that's what eventually leads to hallucinations and delusions. And so a precursor of a hallucination may be an illusion. So for example, you look at a pen, and the pen is misinterpreted by that network because of the pathology of Parkinson's disease as maybe a stick. So rather than seeing a pen, I might see a stick. Rather than seeing a sock, I might see a mouse coming out of that sock. So that's an illusion. There's a stimulus there, there's something there, and the brain misinterprets it. A hallucination, there's nothing there, and the brain fills it in with inappropriate information. And then the delusion is the fixed thought, the abnormal sort of thought process that goes along with that.
Dr. Amjad, now with the illusions, is that something of a pattern, like a floor pattern, like a checkered pattern that might sway back and forth, or a rug?
Yep, great point. So a lot of times that's the way illusions start. They'll start with sort of the pattern on the carpet looks like it shimmers. Or another very common one that I hear is people see like a little crumb on the ground, and instead of it looking like a crumb, it looks like a little spider or an insect or an ant crawling across the floor. And that brings me to my next point. So one of the questions that I'm oftentimes asked, and I get asked this when I'm talking to other physicians and also when I'm doing patient programs, and that is, how do you know when to treat somebody? How do you know if the illusion or the hallucination is problematic enough to treat it? And the answer to that is that the way I sort of look at it is, number one, I never want to treat something when it's an emergency, because when you're backed into a corner, your options dwindle, right? That's a general rule in life. When you sort of wait till the last minute to do something, your options shrink. I recently went on a trip, so if I'm booking a hotel, I want to book it in advance, because if I wait to the last minute, all the good hotel rooms are going to be taken. Same sort of idea. You don't want to wait to the last minute to treat something, because if you do, your options dwindle, and then you're stuck using medications that block dopamine. And if you block dopamine, the motor symptoms of Parkinson's go up, and morbidity and mortality go up. So morbidity is risk of a serious illness. Mortality is risk of death. And both of those go up dramatically if you block dopamine. And all of the older medications that we use to treat psychosis block dopamine. The other reason you don't want to wait till the last minute is that the longer this goes on untreated, the harder it becomes to treat. So the longer this goes on without treatment, those are the patients that oftentimes will need 2 or 3 different medications to treat this. Those are the patients that oftentimes end up in the hospital. And one of the things that I always try and do, I'm not always successful at it, but I always try and do, is try and keep patients out of the hospital. That's a big part of my job, is to keep patients at home and functioning and not in the hospital. But again, that's the other reason you don't want to wait until the last minute to treat this. The third reason is that the way I sort of decide when to treat somebody is when it affects their behavior. One of the myths out there, and I've heard neurologists talk about this as well, is that, well, what about benign hallucinations, or this idea that, well, maybe they'll sort of go away on their own, or they won't get any worse. What we know in Parkinson's disease is that it's a progressive disorder. Just like the motor symptoms of Parkinson's disease get worse, psychosis, hallucinations, and delusions in better than 95% of patients will get worse over time. This isn't something that's going to go away on its own. It's not something that, if you wait for long enough, or this is something that at some point will need to be treated. And we have lots of studies that have shown us this, that over time, this gets worse. I'll give you 2 examples. So if you have somebody, and these are patients that I see, so I'll give you 2 real world examples. So I recently saw a patient who was seeing spiders on the ground, and kind of like what Brian was saying, the pattern on the floor would sort of change, and there would be a crumb on the floor, and the crumb would turn into a spider, and the spider would start to move. One patient would look at the spider and say, "That's my hallucination. I'm going to completely ignore it." And he went on and continued to have his dinner. The other patient, most of the time he said, I ignore it, but every so often I get up out of my chair and I try and step on the spider to make sure it's not real. It's that second patient that needs to be treated. And the reason is the line between what is real and what is not real is blurring. And he's telling me that because his behavior is changing. Okay, so that was a very long answer to your question, Brian. So going back to the slides here, couple of things that are important on this on this slide. So external and internal causes of hallucinations and delusions. Internal causes I sort of think about as things that we don't have a lot of control over. External causes are things that we do have some control over. And so some of these, alcohol and recreational drugs, I think, I'm not going to talk a lot about that. Obviously, alcohol and drugs will increase your chances of hallucinations and delusions. One of the things that isn't on here is that if somebody has a pre-existing mental health diagnosis, for example, there's a history of depression or there's a history of anxiety, your risk, that person's risk for developing hallucinations and delusions is a little bit higher. Some of the medications that are used for Parkinson's disease, and so I want to make a distinction here. Medications don't cause the hallucinations and delusions. The hallucinations and delusions are a result of the pathology within the brain. But there are certain classes of medications that can make the hallucinations and delusions worse. There are 3 medications that I always talk about. So dopamine agonists, a medication called amantadine and its newer cousin Gocovri, and then anticholinergics, things like Benadryl or Artane. Those can increase your risk of hallucinations and delusions. Carbidopa, levodopa, or Sinemet, typically that doesn't increase the risk significantly. Dim lighting or time of day, so oftentimes hallucinations and delusions will increase as the sun is setting and as the light level is starting to decrease. So one of the simple things to do to help with this is just raise the level of light in the house. And so that's an easy one that patients can do without using any medications. For a while that will work, but like I said, this is progressive. Over time, it will get worse. And so I think it's important for patients and caregivers to know that. I want to talk a little bit about this idea of infection. And so there's something called metabolic encephalopathy. The name is not important, the concept is. And that is that Parkinson's disease changes slowly. It changes over time, but typically months and years. So if you see a sudden change, something happens over the course of a week or two, that's typically not Parkinson's disease. That's usually something outside of the brain affecting the brain. And one of the most common scenarios, and my rule is that if anybody tells me that they have new onset hallucinations and delusions, they've never had them and they're starting to develop them for the first time, or there's a sudden increase, I always make sure that there isn't something outside of the brain affecting the brain. So you want to check electrolytes, infection, making sure there isn't an infection in the blood, making sure there isn't an infection in the urines or urinary tract infection. Those things are sort of notorious for doing this. So if you call your physician, that's one of the first things that they're going to ask you about. And they may order some blood work, they may order some urine testing. If somebody's had a fall, they may order some imaging for the brain. So I just want to make sure that, again, the name isn't important. That's called a metabolic encephalopathy. When that happens, the name doesn't matter so much, but the concept does. So if there's a sudden change, you want to look at other things that could be affecting the brain.
Dr. Amjad,
Yeah.
I have a quick question. I'm glad you brought that up because this is an observation. It doesn't mean anything other than this is what I tend to notice. Is it true that as we age, Parkinson's or not, that when somebody has a UTI, urinary tract infection, it's more likely as we get older? Because the one thing I noticed, it just seems, I remember when my grandmother had one and my father had one, and a recent person with Parkinson's who we work with had one. And you would have thought they completely lost their mind overnight with Alzheimer's and all kinds of things. Yeah. And my first thought is UTI, but is it more common in the elderly?
It is. So one way to sort of think about the brain is the brain has a reserve, right? Just like any other organ. I'll give you an example. Take somebody who's a smoker, they have COPD, and they get a pneumonia, or they get a cold. They may end up in the ICU with that cold as compared to somebody who doesn't have COPD, isn't a smoker, and they get the sniffles for a few days and then they go about their business, right? So two very different outcomes. And so the brain has a reserve. As we get older, that reserve shrinks. As we get older, our brain shrinks, and so that reserve shrinks. And so in older individuals, any infection, any electrolyte abnormality puts you at risk for that. And what you're mentioning, the UTI, so I'll give you an example. When I was a medical student, I was rotating out of Fairfax Hospital. It's a hospital here in the Northern Virginia area, a suburb of DC. And I had a patient who came in completely, very sort of agitated, combative, hallucinating. And so I saw her that night, admitted her to the hospital. She had a UTI. We started her on antibiotics, and I came back the next day. She was a completely different person, very pleasant. I was able to have a normal conversation with her. But again, it speaks to your point that UTIs are notorious for causing this. Okay. And that's why, again, go ahead.
I'm sorry. Is there any connection between dehydration and a UTI? Like is somebody dehydrated more likely to get a UTI?
Yep. So think of a lake, right? So if you have a lake, or think of a pond and a lake. A pond typically doesn't have water coming into it and going out of it. It just sort of sits there. What happens to it? You get lots of algae and muck, and it turns green eventually, right? A lake has water coming in and going out. It doesn't do that, right? You can go swimming in it. The water is nice and clean. The bladder is the same way. The more fluid that goes in and out of the bladder, the less likely you are to get a UTI. The less fluid that goes in and out of the bladder, the more likely you are to get a UTI. And when I say fluid in and out, that directly correlates with how much fluid you drink. And so making sure you're adequately hydrated is very, very important.
I really appreciate that. I won't go on anymore about that, but that explains a lot of things. And well, it makes me feel good that I recommend hydration.
Yes, always
it's
hydrate.
So important for everything, right? So important for everything.
Yep. 70% of your body is water, and without water, things don't work well. Okay, so moving forward, so these are the different types of hallucinations. We've already talked about this, so we're going to keep moving forward. The one thing I wanted to mention here, so this is an illusion. The sock sort of looks like a rat. This is a hallucination, right? There's no stimulus there, but in the reflection, he's seeing these children standing there. So that's like sort of a classic example of a hallucination. We've talked about delusions already. Persecutory delusions, this idea that somebody is stealing from them. I've had lots of patients where they will say that the aides are stealing their things at night. So that's a very common one. Jealousy delusions, again, very, very common with men. I don't see it so much with women. In fact, I can't think of a woman patient who's had this, but there are lots of male patients who think that their spouse is cheating on them. So very common delusion. What's the problem here? Here it's the delusion. He thinks that somebody is trying to come into the house. The thing about delusions is that oftentimes the delusion is more problematic than the hallucination, right? It's the behavior oftentimes is more problematic than the hallucination. We've talked about this already, that it is progressive. It will get worse over time. There was a study that was done out of Chicago. I forget the exact numbers, but I think it had 48 patients. And of that 48 patients, I think 46 or 45 progressed from having benign hallucinations to problematic hallucinations. So again, there's lots of data out there, there's lots of literature out there that tells us that this is something that over time will get worse. And so if you choose not to treat it early on, you always want to make sure you keep an eye on it. It's something that is so common that at every visit with every patient I see, I always ask them about this.
Seems like there can be some fear associated with some of these. And that in itself can really cause, I suppose, a more likely risk of falling and just all kinds of problems. Movement, compromised movement. And I had a gentleman in
Yeah.
Maine a couple of years ago. I was teaching up there, and he knew that he was seeing things that weren't real, so he wasn't afraid. Whenever he went outside, walked down the road, every fire hydrant he saw, he said, "Well, I see a dwarf waving at me, but I know it's not a dwarf, so I'm not afraid." Then there's the other people who see things that they believe are real, and they're afraid, and
Right.
tend more to fall down.
Yeah. So you bring up a great point. So if you look at falls are more prevalent in patients that have hallucinations and delusions.
Mhm.
The other thing that you bring up is that they may not be scary for patients. For some patients, it may not be scary. It may actually be very pleasant. I'll give you an example in a second, but it is distracting, right? And so if you think about Parkinson's patients, one of the things that happens in Parkinson's disease is it can affect your cognitive function. So if you're distracted by these hallucinations all the time, you're not going to be able to focus on what you're actually trying to do. Parkinson's patients need a lot of focus to walk so that they don't fall. And so if you're distracted by hallucinations all the time, you're not going to be able to focus on the task. So that's something that I see very commonly. I'll give you an example of a hallucination that for this particular patient was very pleasant. So I had a patient, again, this was a few years ago, and she used to see her grandchildren lived out of state. So, she sort of missed them and she didn't get to see them very often, but she started seeing these children that would come into the apartment, and it was her husband and the patient, and so they lived in the apartment alone, and these children would come to visit every evening. And initially it was a very pleasant experience for her because it was almost a substitute for the grandkids that lived out of state. Over time, though, she started cooking for these children, and all of a sudden it went from being something that was not much of an issue, was fairly pleasant, to being a significant issue because the husband said that she's cooking for 10 to 11 people every night, and it's just the two of us here. So it's the behavior that really matters. And maybe early on when she first started seeing the children, perhaps we didn't treat it, but as it progresses, it will need treatment. The other thing that I would caution people against, or the other piece of caution that I would have, is that there's no way for me to predict when a hallucination is going to go from being not problematic to being problematic. I don't have a tool that allows me to make that prediction. And if somebody is having formed hallucinations to the point where they're seeing a person or a dwarf or children, that brain is telling you that there needs to be an intervention there because it will progress. Okay.
Sure, yeah.
The other myth out there is that hallucinations and delusions are dementia or Alzheimer's disease, and that is just not true. There are lots of patients with dementia who have hallucinations, but there are also lots of patients out there without dementia who have hallucinations. So it's important to make that distinction. One of the common things that happens in Parkinson's disease is something called Rem Behavior Disorder, this acting out of dreams. And so it's important to, and then the other thing that happens in Parkinson's is that the dreams can be very lifelike. Important to make a distinction between the two because the treatments are very different. Hallucinations are when somebody is awake. That's very, very important to keep in mind. This is not something this is not a dream. This is you're fully awake and seeing something that isn't there. Let's go to the next slide. So we've talked a little bit about dopamine and serotonin already. Let's see. The one thing that I will mention is about 50% of patients with Parkinson's disease at some point during the course of their illness are going to have to deal with this. As I mentioned earlier, it is one of the leading causes of patients having to leave their home. If you look at the emotional toll on the caregivers and you compare it to if you look at depression scores, for example, in caregivers of patients with Parkinson's, but without hallucinations and delusions and compare them to depression scores in caregivers of patients with Parkinson's disease and hallucinations and delusions, the depression rates and the anxiety rates in caregivers are much, much higher. So it's not, this isn't something that just impacts the patient, it impacts everybody around them.
Mhm. Yeah.
We've talked a little bit about this already. Some of the things that you can do to some of the non-pharmacological, non-medication techniques that one can use. So something as simple as raising the light level, talking to your loved one, reorientation, telling them where they are, what time of day it is, what time of year, what the date is, who you are sometimes. For a while, those things can be very helpful. And you always want to do that before you go to medicine. But if you're in a scenario where you find yourself doing that 7 or 8 times a day, and sometimes it works and sometimes it doesn't work, again, what that person is telling you is that they need more help. They need an intervention with a medication. So establishing a plan of care, and again, I can't emphasize this enough, it is critically important that if this is happening, that you bring it up with your physician, because chances are your physician isn't going to bring it up. We won't get into the reasons of why that happens, but important to recognize that 80 to 90% of people that are having this don't voluntarily bring this up. And again, the reason, like Karl, you were saying, is fear. Right? A lot of times people think they're losing their mind, or, oh my God, I'm getting dementia, or, I'm embarrassed to talk about this. And those are all valid feelings to have, but it's also important to recognize that this isn't something you have to live with. And this is something that will get worse over time. So it's important to identify it and treat it. Were you going to say something?
Oh, no. I'm shaking my head because this all makes sense.
Yeah.
Yeah, really appreciate what you're doing here, sharing with us, because actually with as much experience as I have and as many conferences as I've been to, and as much research as I've done, and writing a book and citing, for my book, you're always teaching us so much. And we look at this, there's so much you added today that I really appreciate. I won't say what it is because I don't want to take up your time, but I learned a lot from this, and I keep going. I go as long as you want, because this is really great for us to be learning from you.
Thank you, Karl. I appreciate that.
Hey, Doc, quick question.
Yeah.
When you see patients, what are some things that do the caregiver bring it up most of the time, or do the patients? And what is their delusion? Why is it small children and animals? Do we know why that
no? I'll sort of, so I don't have any data to back up what I'm going to say next. This is purely my opinion. But what I think happens is delusions or hallucinations are sort of guided by your previous life experiences. I had a musician recently, and he would hear drums. That was his hallucination. He had an auditory hallucination. For women, a lot of times it's children that they see. So I think some of this is determined by your previous life experiences. The way I sort of think about this is that the brain doesn't like having a vacuum. And so the brain will always, if there's a lack of information there, if there's, the brain will fill it in. And it won't always fill it in accurately. But what it fills into that space a lot of time is determined, in my opinion, by its previous experiences. And so, there's no rhyme or reason to what people see or what they hear or what the delusion ends up being. In terms of who brings it up, in my clinic, and I think my practice is a little bit different because, again, I primarily see Parkinson's patients and I see so much of this. I'm usually the one who brings it up because I'll always, at every visit, I ask patients and their caregiver. It's important to ask both the patient and the caregiver. It's a team approach. So I'll always ask. Sometimes it's the caregiver, sometimes it's the patient. But like I said, there tends to be a stigma associated with bringing this up. And then the other caveat to that is that oftentimes when the caregiver or the patient bring it up, it's a crisis. Rarely do I hear about the spider on the ground or the pattern on the ground changing. That's when you want to hear about this, because that's when you want to intervene. You don't want to wait until it's a crisis, but a lot of times when patients and caregivers are bringing it up to me, it's at the point where it's a crisis. And again, my options are much more limited at that point. So again, I hope one of the things that people will take away from this is that if this is happening, don't be shy about it. You can be shy about it, you can be embarrassed about it, but also recognize that it is important to bring it up and get some help for it. Okay. So let's see. I'm gonna skip the summary slide, and I want to get to pimavanserin, and I'm gonna try and wrap it up in the next 5 to 10 minutes so we have some time for questions. And I went a little bit longer than I meant to. So pimavanserin is the first medication indicated for the treatment of hallucinations and delusions associated with Parkinson's disease psychosis. It has a very narrow indication. I can't give this to somebody with schizophrenia. I can't treat Alzheimer's patients with this. It's very narrowly indicated for patients with hallucinations and delusions associated with Parkinson's disease psychosis. So one of the things that's important, I think, to recognize is some of the history of how we used to treat this and how it's treated today. And so remember what I said, all of the antipsychotics prior to pimavanserin or Nuplazid were number one, block dopamine receptors, specifically the D2 receptor. The specifics don't matter, but the main point being that they block dopamine receptors, and that they were studied in psychiatric patients. And they were primarily studied in patients with schizophrenia. So what's one of the biggest differences between patients that have schizophrenia and patients that have Parkinson's disease? And the answer there is it's their age, right? Patients with schizophrenia tend to be in their 30s, 40s, and 50s. It's a young person's illness. Patients with Parkinson's disease tend to be in their 60s, 70s, 80s. It's an older individual's disorder. And so one of the biggest problems that we had prior to 2016 is that we didn't have a medication that was specifically studied in older individuals. All of the medications we used were studied in younger individuals. And that's a problem because a 40-year-old's body, their physiology, the way their body works, the way their brain works, is not the same as if you took that same person and made them 80. Okay, so that's an important distinction. We finally have a drug that was studied in the age-appropriate group of patients. So the average age of the patients in the study, in the pivotal study that led to the approval of Nuplazid by the FDA, was 72. Okay, and that I think is critically important because a 72-year-old is not the same person as a 42-year-old. The second point is that it was studied in a disease-specific state. So all of those other medications were primarily studied in schizophrenia. The pathology or the abnormalities in the brain in schizophrenia are very different from the abnormalities in a patient in a brain of a patient with Parkinson's disease psychosis. So this was specifically studied in patients with Parkinson's disease psychosis. Okay. It comes with a black box warning. A black box warning is something that you will see on every antipsychotic within the United States. It's a class-wide warning. And so the FDA, the first bullet point is the black box warning that you will see with any antipsychotic that's available in the United States. The second bullet point is the modification, and I'll talk about why the modification is there. Remember what I said earlier, that every other antipsychotic works on dopamine. Pimavanserin or Nuplazid doesn't touch the dopaminergic system at all, doesn't affect it at all. Only works on serotonin, and specifically works on one type of serotonin receptor, the 5-HT2A receptor. The name doesn't matter, the concept does, and the main point here is pimavanserin doesn't work on dopamine at all, only works on serotonin, and binds to this one particular receptor and basically shuts it down. That particular receptor seems to have a lot to do with psychosis. And so the idea is that if you can shut down its activity or decrease its activity, you should have an improvement in psychosis. So the black box warning has a modification, again, because the mechanism of action of pimavanserin is a little bit different than all of the other antipsychotics. So the first part, I'll just read it out. So medicines like Nuplazid can raise the risk of death in elderly people who have lost touch with reality. So people that have psychosis due to confusion and memory loss, which is dementia. Nuplazid, so this is the modification. Nuplazid is not approved for the treatment of patients with dementia-related psychosis, unrelated to the hallucinations and delusions associated with Parkinson's disease psychosis. So that is the FDA's way of essentially saying that if you have Parkinson's disease and you have psychosis, it is okay to take Nuplazid even if you have dementia, okay? Whether you have dementia or not, if you have psychosis, as long as you have Parkinson's disease and you have psychosis, it's okay to take Nuplazid, okay?
Okay.
So we've talked a little bit about how Nuplazid works. So I'll talk very quickly about the clinical study. So as is true of any clinical study, the FDA essentially requires you to show two things. One is efficacy. Does it actually work? Does it do what you claim it does, or the pharmaceutical company claims it does? Two, is it safe? And the way the FDA does that, or the way it's typically done, is you take the drug and you compare it to sugar pills and or salt pills, placebo. And you do this in a blinded manner. So the patients randomly, they come into the study, half the patients get assigned to placebo or sugar pills, the other half of the patients get assigned to the active drug. I, as the investigator, don't know who's getting the active drug and who's getting placebo. And patients, as participants in the study, also don't know who's getting the active drug and who's getting placebo. So that's what it means when we say blinded, randomized, placebo-controlled study. It's placebo-controlled, you're comparing it to sugar pills. It's blinded in that I don't know who's getting the drug and the patients don't know who's getting the active treatment. And it's randomized, meaning I don't cherry pick the patients that I put in the placebo group versus the treatment arm. It's randomly done by a computer. And so at the end of the study, we interpret the results, we compare the two groups, and then we open up the books and say who got the treatment and see, is the group that got the treatment better than the group that got placebo? And so that's the way all studies are done. And that's the way this study was done. And what they were able to show is that there is a statistically significant reduction in both hallucinations and delusions in the group that was treated with Nuplazid as compared to pimavanserin. One of the things we saw in the study is that it can take up to 4 to 6 weeks. In my experience, it can take up to 6 to 8 weeks to actually see a reduction in the hallucinations and delusions. So this isn't a drug that works right away. And that's the other reason you don't want to wait until the last minute. You want to have enough time for the drug to actually take effect. Not everybody, as is true of any drug, not everybody is going to have a benefit from this, but most people will have a clinically significant benefit from it. And so I think it's the number is 65% of or so of patients will have a meaningful response to the drug.
That's great.
The other piece of this, again, remember I said it doesn't touch dopamine, because I can give a patient Haldol and I can make their psychosis go away. But I also will worsen their motor function to the point where they can't get out of bed, right? So it's not just, it's also important that the drug is safe. And when we say safe in Parkinson's disease, a lot of that has to do with not worsening their motor function compared to placebo or sugar pills. And the drug doesn't seem to interact with the typical medications used to treat Parkinson's disease, so it can be used without having to adjust the doses of the carbidopa, levodopa, or whatever other adjunctive drugs that a patient may be taking for their Parkinson's. So it's important to know the side effects anytime you take a drug, and so you can see the side effects there. The things that stood out in the study were swelling in the legs or arms, so 7% compared to 2% for placebo. And then a side effect that happens less frequently, but it is something that I always talk to patients about, is something that is obvious. You know, patients with psychosis, some days may be good, some days may be bad. But if you see this is going to be an obvious change. Doesn't happen very often, but it is something that you need to be aware of. And again, any medication that treats psychosis has the potential of worsening what you're trying to treat, including Nuplazid. So you always want to be aware of that. QTc prolongation. So QTc prolongation with Nuplazid alone is thought not to be significant. However, there is an additive effect. So if you're on another drug that also prolongs QTc, your physician has said, you know, this drug prolongs QTc, you need to be aware of that. Or you have congenitally prolonged QTc. So you for whatever reason, your heart just normally has a prolonged QTc interval, you need to let your physician know that. It is cleared by the liver. There are two ways that your body clears medications and toxins, either the kidneys or the liver. Nuplazid is cleared by the liver. So again, if you have any liver issues, you want to make sure you let your healthcare provider know, and you always want to go to your physician with a list of medications, the dosage, and how often you take it. That's incredibly important. It comes in a 34 and a 10 milligram capsule. The recommended dose for most patients is 34 milligrams, and it's easy to take. It's once a day. You can take it at any time of day, just once a day, 34 milligrams. Insurance cost. So for most Medicare patients, what I'm told is cost should not be an issue, because I think the average cost, and Brian, you can correct me on this, is like $25 or $30 for most Medicare patients. Am I right on that?
Yeah, it's actually going to be less than that. So
it's less than that. Okay.
Yeah, 8 out of 10 patients pay less than the $15 copay. So most of it's going to be covered on Part D plans. And I recommend them calling the 1-844-734-2223 Acadia Connect if they have any questions with cost, or if the cost is too high for their income level, and work with Acadia on that.
Good. Okay. So I'm going to skip the summary slide in the interest of time. I'll be happy to answer any questions.
Any questions out there? If so, let's put them in the chat box. We have one question here, but you already answered that one. Anyone else? I learned a lot today.
Well, good, Carl. You had some great questions.
I think that, you know, this area, like Brian and I have talked about a lot, this area of delusions, hallucinations is not touched upon nearly enough. And it really needs to become common knowledge. And even in the medical, well, in the medical world first, I would say, just because you're on the front lines. And, you know, nothing against anyone. We need our neurologists pretty much no matter who they are, but I wish that they would jump on board and start considering these things, because it's such a big deal.
Yeah, it is a huge deal. And again, it's something that is so debilitating, not just for the patient, but that family dynamic. It usually pushes people apart. And you know, I've seen loved ones cut their food for the patient, bathe them, help them walk, But when this stuff shows up, they really don't know what to do. And the sad part is that neurologists, we haven't really sort of taken ownership of this. And again, there are lots of reasons why, but a lot of this change is going to come from patients. I think, unfortunately, it's going to be patient driven. And so, yeah.
We have two questions here, just real quick.
Okay.
The first one is, do they use Nuplazid for non-Parkinson's dementia? And the second one, how concerning should verbal aggression go on be if there's verbal aggression happening?
Okay, so let me talk about
relative to
aggression first.
Like in relation to hallucinations, I'm reading this right. How concerning should aggression be verbally?
Aggression is incredibly concerning. And so one of the first things to say is, if somebody is being aggressive, you don't want to get into a confrontation. Okay. Remember, hallucinations and delusions are not amenable to reason. You're not going to be able to reason with somebody. Don't get into an argument. Don't get into a confrontation. That will not go well. Okay. Disengage if you can. If you think you're at risk, or you think things are really out of control, then unfortunately, you may have to call 911. But aggression is incredibly concerning. When I hear aggression, that to me, one, it tells me that we're sort of behind the 8 ball. We should have done something about this before it got to this point.
Sure.
But it is definitely a sign that this needs to be addressed, and it needs to be addressed ASAP. But the key message for aggression is that it is incredibly concerning. Do not get into a confrontation. Do not get into an argument, and get help. And sometimes that help may mean calling 911, or if you have a little bit more time, it may mean going to your physician and getting this treated. The other question was, can you use Nuplazid for non-Parkinson's dementia or non-Parkinson's disease psychosis, right? So the answer to that is that the current indication that the FDA has for Nuplazid is very narrow. It is only indicated in Parkinson's disease psychosis. Whether they have dementia or not, it doesn't matter. If you can use it in patients that have PD psychosis and dementia, and you can also use it in patients that have PD psychosis and no dementia. It is currently not indicated for Alzheimer's dementia or any of the other forms of dementia. There was a recent study that was done. You can look that up on your own, that did look at Nuplazid being used with other dementias. But as it stands currently, the FDA only has approved Nuplazid for Parkinson's disease psychosis, with or without dementia.
That is very helpful. I really appreciate this. This is really, really good, really great information. I hope we can do this again at some point and learn more.
Absolutely.
Yeah.
Thank you, Karl. Thank you for having me. And Brian, thank you for inviting me and setting this up. So
yeah, we really appreciate this.
Yep.
And I'm going to stay on and do a brief thing here real quick for anyone watching. But Dr. Amjad, thank you so much again. Appreciate this greatly.
Thank you, Karl. It was a pleasure. Thank you, Brian.
We'll talk to you soon, Doc. Take care.
All right.
Sounds good. Bye-bye.
All right. See ya.
All right. All right, gang. I'm going to do something real brief here.
Hey, Karl, as you're doing that, I just want to follow up,
Yes.
Thank everyone for jumping on. I think it's truly important that we educate ourselves with Parkinson's disease and the diseases that are associated with it. During a pandemic, it's extremely important that we understand the mental health part of Parkinson's, the jealousy, the rage, the anger, the hallucinations, delusions. Those are all things that increase our risk of being hospitalized. And as a Parkinson's patient, we know that we do best in our own homes. We want to stay out of those emergency rooms or those hospitals. We don't. They are understaffed and they are doing the best that they can. But as Parkinson's patients, we need our medicine on a certain time. and that's just not happening all the time. So I think there's two things to, we tend to, as the sun goes down earlier and earlier, and people in the Northeast, or as winter comes in and we're in our home more often, we tend to see more dementia, more hallucinations associated with Parkinson's. So keep that in mind. Keep your options. You definitely want a non-pharmacological, you want to exercise, and you want to get daylight as much as you can. When that stops working, or when you need more, that's when you want to go to the pharmacological medicine for the Parkinson's disease psychosis. So I hope everybody learned a lot. I definitely did. I've seen so many people that have had hallucination delusions and not talked about it, and have hurt themselves by broken limbs or hips, by tripping or falling over something that they saw run across the hall or the rug, or just trying to jump over something that's not there. So it's never a good thing, and it's always hard to come back from that. So Karl, I just want to say thank you again. Together,
my pleasure.
We're
my
definitely
pleasure.
Thanks.
What I'm going to do, I'm going to, just in the interest of time, and I have somebody here I'm going to be working with in just like 1 minute, I want to show you one thing, gang. Because Emily's going to start working with somebody here in just a second, but I'm just going to real quick, folks, real quick. Boom, boom, boom. Falls major concern, our most primary concern in Parkinson's. Well, you can learn a lot about this and how movement lights up the brain, and how we can do, gamify movement, do it outdoors, use music, and stimulate our plantar skin to help us get more proprioceptive input, more interactive environment, to wake up the nervous systems, activate the brain, right? Sorry. And including, if you have access to any kind of vibrating devices, for example, I use on the right, those are my power plate vibrating devices. They're the best ones I've ever used. They all vibrate. It's all amazing. We can use this for a lot of different things. But when we look at total body vibration, which this machine on the left from PowerPlate, we're really lucky. The top model's coming in here in the next day or two. There's a lot we can do here. Now, not a lot of people don't have access to this, but just go back to walking around barefoot, stimulate your feet, get some sensation into your nervous systems and your brain, and immediately have more proprioceptive input and reduce chances of falling. And I'm totally going backwards here instead of forwards. Pretty much I want to skip through because I need to run in just a minute. In a video that is, I'll post it later. In fact, I'll send out a follow-up email with a link to this recording. And then I'll also have another link that shows about how to maximize neuroplasticity. That is the brain's ability to change itself and retrain itself so you can learn a new skill, learn to move better. You have parts of the brain that are affected and not communicating with each other appropriately in Parkinson's, and causing impaired movement and cognition and various things. So we can work on this and maximize neuroplasticity. All right, so we go through that in the video that'll come in the email along with this one from another presentation. And basically with that, I'll just say that if you go to Amazon and look up this Parkinson's regeneration training, I wrote a book and it's out there for people. So, or the pdbook.com, you can just go there and buy it. Although if you're outside the United States, it's going to cost you a lot for shipping. So just go to Amazon. If you can't get it there, then go to the pdbook.com and I'll send it to you. Okay, so Brian, thanks a lot, man. I'm going to run along and get busy working. Thanks everyone for being with us, and we'll be doing this again here down the road, and I'll keep everyone posted.
Take care. Thank you, everyone.
Thank you. Thanks a lot, everyone. Thanks, Brian. Bye-bye.